Hi, I'm Stephanie Jackson Cullison, and I'll be discussing how genetic information can help stratify melanoma risk in pigmented lesions. In this webinar, I will show data from a small study I did in collaboration with DermTech that illustrates differences in gene expression among melanoma, severely dysplastic nevi, and lower risk lesions. The diagnosis of early melanoma is challenging. The current standard for detection is visual assessment, followed by biopsy and histologic evaluation. Using the current pathway, we biopsy a large number of pigmented lesions annually to diagnose a single melanoma. In a recent meta-analysis, the number of lesions biopsied to diagnose one melanoma ranged from 2 to 30, with a mean of about 15 biopsies among all clinicians. Now, biopsies carry risks of pain and scarring and can be distressing for some of our patients. Certainly, subjecting our patients to these risks is justified if the pathway effectively identifies melanomas and there are no better alternatives. However, the current pathway has low sensitivity and specificity for early lesions. So shown here are sensitivities in the low 80s, specificities of less than 32%, and a probability of missing melanoma as high as 17% with the VAH pathway. Genetic information can aid in distinguishing melanoma. So LINC and PRAME are two genes differentially expressed in melanoma and non-melanoma lesions. Current technologies, such as the DermTech pigmented lesion assay, allow us to non-invasively evaluate expression of these genes using adhesive patches applied directly over concerning lesions. This technology improves sensitivity and specificity of melanoma diagnosis while reducing the probability of missing melanoma to 1% and decreasing the number of biopsies we perform. It has been proposed that progression of pigmented lesions to melanoma is driven by a sequence of gene mutations. The PLA can also evaluate for genetic mutations associated with early melanoma, and combining that information with LINC and PRAME expression further enhances the sensitivity of detecting melanoma to 97%. The majority of existing tools to evaluate risk in pigmented lesions focus on distinguishing melanoma from non-melanoma lesions. However, this approach largely ignores intermediate risk lesions known as dysplastic nevi, which share overlapping clinical and histologic features with benign and malignant nevi. Dysplastic nevi are significant because they increase an individual's risk for developing a melanoma and are themselves potentially a melanoma precursor. The problem with dysplastic nevi is that histologic diagnosis is not highly reproducible. Shown in this table are histologic observer agreement for dysplastic nevi. As you can see, agreement ranges from 25% to 63% among dysplastic nevi and early melanomas. And the accuracy of a single pathologist arriving at the consensus diagnosis for these intermediate lesions is between 25 and 43%. These data raise concern that lesions diagnosed as severely dysplastic nevi may actually be early melanoma. Indeed, these groups are not even distinguished in the Empath DX classification system used here, which stratifies lesions based on management recommendations. This slide illustrates the most common management schema, whereby severely dysplastic nevi are considered higher risk lesions and managed with excision. Because histologic features are thought to be genetically driven, we hypothesize that gene expression and mutations may help distinguish severely dysplastic nevi from lower risk lesions and melanoma, and that these data may provide insight into melanoma evolution. In this study, 103 patients with concerning pigmented lesions had their lesions non-invasively sampled and subsequently surgically biopsied. Gene expression and mutation analyses were performed on the non-invasive samples, whereas biopsies were read by 3 dermatopathologists. The data were subsequently compared. In the non-invasive samples, expression of link and PRAME, as well as mutations in TERT NRAS and BRAF non-V600E were evaluated. So shown here are link and PRAME and TERT status for our low-risk lesions, our severely dysplastic nevi, and melanomas. Notice that link and PRAME positivity increases with the degree of histologic atypia. And among our higher risk lesions, the severely dysplastic nevi and the melanomas, a higher proportion are doubly positive for link and PRAME, shown here in the dark gray bars. Among the driver mutations, TERT mutations were the most common and found to be clinically significant in their ability to stratify risk among lesions. As shown here, only a single lesion from each of our lower risk categories, the severely dysplastic nevi and the non-melanoma lesions, harbored TERT mutations, whereas the majority of our melanomas were positive for TERT mutations. Interestingly, all of these lower risk lesions that were positive for the TERT mutations were also doubly positive for link and PRAME, suggesting these lesions may be inherently higher risk. To summarize, link and PRAME expression and TERT mutation positivity increases with the degree of histologic atypia, supporting the idea that the spectrum of atypia across pigmented lesions is genetically driven. TERT mutation status specifically enhances the ability to distinguish melanomas. The pigmented lesion assay is capable of identifying lesions with these early genetic markers of malignant potential and improves our ability to stratify risk in pigmented lesions. All of this information can be obtained non-invasively, thereby reducing the number of biopsies we have to perform to diagnose a single melanoma. Thank you for watching, and please let us know if you have any questions.